Okay, good afternoon, everybody, and welcome to our next instalment of our shared learning event for Align 16. My name's Mark, and I'm joined today by Nick, Sharon, and Callum in the chat room. Just before we go on to our guest speaker today, I'm just going to go to Andy for some important messages. Thank you, Andy. Next slide, John. Thank you.
Thanks, Mark. Thanks, John. So for those who've joined these sessions previously, we're going to follow a very similar format, largely because they've worked fairly well for us, really. So if we could ask for participants when speaking, if we could have the camera on, and when not speaking, if we could ask people to mute just to cut down on the background noise, really. What we'll do, John's going to give his presentation shortly. We'd really invite any comments or questions in the chat box throughout the presentation, and then towards the end, we'll take it to a Q&A session where we'll explore anything in the chat box and also open it up to a kind of a virtual hands-up approach for anybody who's got any questions at the end as well. So that's the format that we'll follow. And I guess back to you, John, then for the or is it back to you, Mark?
Yeah, thanks, Andy. Just before we move on to our guest speaker, just to say that because of the demand for these sessions, we've now extended the invitation to the rest of the country. So hopefully we'll be getting colleagues, both old and new, joining us on these sessions. So over to our guest speaker. Our next guest speaker is Dr. John Dean. John is the Clinical Director for Quality and Safety and Patient Safety at the Royal College of Physicians. John, thank you very much for joining us today, and over to you.
Great. Thank you very much, and thanks for asking me to talk. So yes, I'm a physician in East Lancashire, previously in Bolton, and privileged to be Clinical Director of Quality Improvement Patient Safety at the Royal College of Physicians. So what I'm going to share with you in the presentation, and I'm expecting it to take about half an hour, is the work and recommendations of the Modern Ward Rounds report, which is a joint report of Royal College of Physicians, Royal College of Nursing, but also incorporating NHS ESIST, GIRFT, Royal Pharmaceutical Society, and the Chartered Society of Physiotherapists, but much wider engagement in this work. So a little bit of background, first of all. Royal College of Physicians with Royal College of Nursing produced a report in 2012 called Ward Rounds in Medicine Principles and Best Practice. And whilst that's a very well referenced document, I think it's fair to say that people have struggled with implementation. And when we came to review this, we were surprised how much the world had changed in the years since 2012 in terms of the way people work on wards, some of the benefits and some of the challenges that people see. So we brought together a multi-professional group with strong patient involvement to review what was good practice in terms of multidisciplinary working on wards. One of the first things to say is that probably for the first two meetings, one of the things that we discussed was whether we should call this ward rounds or whether we should call it multidisciplinary working in wards. But we came to the conclusion that ward rounds was common parlance, but what it is common parlance for today is multi-professional decision-making, problem-solving, prioritisation, working with patients, communicating with patients in a multidisciplinary team, and that is delivered in lots of different ways. But when you start to look at it from a systematic and a process point of view, it incorporates some really clear processes and also important things around culture and environment that are necessary for good decision-making, good communication, good planning and good delivery of care. So I just want to put that broader context before we start. So what we did for the programme of work that produced the document was that we surveyed professionals. Around 5,000 professionals were surveyed around what was happening at the moment in their own wards, in different sectors and different settings across professional groups. We held a workshop with patients and carers, which was very informative and influencing. And we asked for examples of good practice, and we had literally hundreds of examples of good practice coming in. So everything that is contained in the report is actually happening in the NHS today, but it's not all happening together, and it's certainly not all happening consistently. So whilst multi-professional decision making, problem solving, prioritisation and planning and communication does happen on ward rounds, it also happens in lots of other activities that happen in inpatient wards, and those are outlined on these slides. But what's important is that these are interacting with that, what we'll term ward round process, so that there's an interaction between all these other multidisciplinary events and that core multi-professional, patient-involved decision-making process. So when we asked the different professional groups what their experience was of healthcare delivery in multidisciplinary teams focused around ward rounds, what was interesting was we got very different perspectives from different professional groups, and you'll see here a bit of dissonance in perspective, in that a lot of physicians were saying that the working with nurses in ward rounds was not happening very often, whereas nurses were saying they participated in ward rounds 61% of the time. So there's a difference in perspective here in terms of what we actually mean by multidisciplinary working and how that works. And you can see a similar dissonance relating to pharmacy working with physicians and other members of the professional team. And also you'll see on this slide that actually other professionals really felt it was vital that they were part of this multi-professional decision making, but actually were impeded to do that for various reasons. One of the key elements that we wanted to emphasise was that whilst multidisciplinary involvement and decision making is key, and indeed follow-on is key, it doesn't mean that all those professionals have to be together all of the time of a traditional ward round process, but we need to define the interactions between those different members of the professional team and the patients so that that decision making is collaborative. Okay, so the membership needs to be consistent, needs to be agreed in the different clinical unit area. We also, at the top level, describe some fundamentals, and you can see these on the slides. So multidisciplinary working needs to be well led, and ward rounds need to be well led. There needs to be protected time from a medical point of view, and there needs to be a clarity from the other professional members' roles in terms of them being involved in that. So agreeing roles, agreeing time is absolutely key. And creating that culture of involvement through leadership of the multi-professional team and the patient is key. Structure is key. So these don't just happen, okay? They need to be planned, formulated, and practice may need to change. So some of that structure is about prioritisation of patients, some of that structure is around documentation, some of that structure is around the different roles of the team members. So how those teams work together as effective teams is key. You've got to make sure that there aren't conflicts in the time of professionals to come together, that there's a structure across the day, and we'll come on to this in a little while, and that there's continued briefing and debriefing of the multidisciplinary team through the day. Patient involvement is central and was one of the things that really influenced this report from patients, and we'll highlight that in the slides as well. And ward rounds and multidisciplinary working, again, don't just happen. People need to be trained and educated in how to work in this way. There's a skill, a development element, but also that multi-professional working is an opportunity for cross-professional learning and education, and they're a real opportunity for that to be delivered. Scheduling is one of the most important prerequisites for good multi-professional working in ward rounds. So schedule when the different elements of multi-professional working are going to happen. Common things that we find is that people's shifts start at different times of the day. Things will be planned when one member of the professional team hasn't even started their day, or where they're meant to be somewhere else. So planning and scheduling the ward activities with the multi-professional team is central. We've got to include before and after ward round activities in that schedule. And again, we'll come on to that in a minute in more detail. That scheduling has to optimise patient flow. And personally, I think there have been some conflicting messages about this in the NHS, and we'll touch on that again, because what we've got to have for good flow is good decision making and follow through, not just early decision making, but good decision making. Really important that people adhere to the schedule, that things don't go on too long, because actually we don't make good decisions if it takes too long. And there's some examples of really good practice that we share around how we can use things like dialogue scripts so that people can pace multi-professional working and decision making. Interruptions are a key problem with multi-professional working and ward rounds. So we have to plan ways in which interruptions can be minimised. And also, if there's work to be done outside the wards, that needs to be key. One of the important things around interruptions is the role of the coordinator of the ward versus the bedside nurse in ward rounds. And our recommendation is that the main input to ward rounds is from the bedside nurse, because they tend to know the patient best, and is that the coordinator touches base with the ward round at appropriate points. Because if the coordinator is on the ward round, if they're coordinating that ward, they will be interrupted. And from our surveys, people were saying between 20 and 30 times during a normal ward round. If you want uninterrupted time, you have to plan for it to be uninterrupted. So let's go through the way a ward work, or we say a ward should work, and that good wards do work. So the day starts with a shift handover, and that shift handover needs to be structured, and structured in a way not only so that people know what's happening to the patients, particularly what's happened to them overnight, but also so that that information can then feed into the multi-professional team for further decision making. So the first emphasis in this work is getting good structured shift handover. Then there needs to be the board round or the huddle, whatever you happen to call it, where the whole multi-professional team and other members of the ward-based team come together to take stock of what's happening today and what needs to happen today, who's around, are there any gaps, are there any risks, who are we going to prioritise, who needs to do what in that team to pull the information together. We are recommending then that there is then a need for all of the information for decision making to come together before that ward round process. Some of that might have happened between shift handover and the board round. Some of it may happen after. Some of it may happen in parallel with other patients being seen. But unless you have all the information together for decision making, then we're hoovering up information during the ward round, which is not an efficient way of using our time, and we don't make the right decisions, and patient care is less good and is slower. So you'll see the key components here of information that needs to feed into that multidisciplinary ward round. There needs to be a briefing in terms of the purpose, in terms of roles, in terms of what's going to be achieved. So that's key working up for the ward round. Part of it is also understanding patients' questions and concerns that can be fed into that interaction, and what individual professionals may peel off from the board round, go and do individual professional reviews, and then come in to help that decision making with those assessments. So when we started to look at the key processes in decision making and at a multi-professional level in the ward round, there are these elements. So clearly the patient needs to know who's involved. There is discussion and decisions around key elements of care that you can see outlined here, and then you need to consolidate those into a plan, document the plan, communicate the plan, and make sure it's being followed up through the day. Now, this seems an awful lot of information and decision making to make, but if it's well structured and that preparation is done, then most of that information will be available, And actually all that needs to happen is the different members of the professional team need to highlight where the team needs to focus because there is a concern or an issue in that area. Documentation is key. Clearly, many people are moving to electronic documentation, but I think will be a time before everybody's at that point. But structured documentation can really help with firstly making sure that we're covering all the areas and that information is available. Secondly, incorporating checklists as part of that documentation, so they're not separate from the process but incorporated into it, safety checklists. Thirdly, that we're documenting the decision making, not just the decisions, and then also that we've got documentation that we can share with patients and families and colleagues, which is really clear. So structured documentation is a core element of the ward round process. So when we talk to patients and families, these are some of the things that they said to us, and you can read them as well as I can. But what really struck us was that what's outlined on this slide really. Clearly, patients and families want to be involved in discussions and decisions. They want to see the team working well. They see the ward round as an absolutely vital part of their day and look forward to it, expect things out of it, want to have the information explained, want to know what's happening afterwards in terms of their care plan being followed through. And that good process gives them confidence in the care that's happening with the team working together and that information being shared. So a few things that one needs to consider in communicating with patients and relatives for good decision making. In advance of the ward round, it's important that patients understand what the process is going to be and understand what the other processes are which will help that decision making. It's also important that if there is a need for someone else to be present, that can happen at the time when the multi-professional team is there. There should be an explanation to the patients in terms of ward rounds, in terms of the normal patient information that's available. And clearly, we need to make arrangements for people that have communication issues. That's particularly highlighted when we're using PPE as well. And then during the ward round, very simple things. Make sure that whoever's communicating is actually sitting at eye level with the patient to have that conversation. That makes a massive difference to the hierarchy, to the understanding, to the communication. Make sure we're addressing patients' questions and concerns which may have been highlighted before the ward round. And if you can, leave a short note for the patient explaining what's happening. Again, we have examples of good practice where this happens as a routine part of practice in some wards in the UK today. And again, electronic systems can help us to do that. So real emphasis on that patient, relative and carer involvement. And what's interesting, and I'll touch on it at the end, is that the improvement work that we're doing in collaboration with ESIST is that patient-centred patient involvement is the primary priority of many of the teams that are working on improving ward round. So you've had your shift handover, good information is transferred to the ward round and is available for the ward round. You've prioritised who you're going to see, who's going to do what to pull that information together, how the team's going to work, and then that collective decision making for the ward round. Perhaps one thing I didn't highlight was the key roles in the ward round, knowing who's leading it, knowing who's keeping notes, who's the advocate for the patient, who's the key communicator. All of those things are key roles, and they can be, one person taking a number of those roles. So you finish the ward round. It's important to have a debrief in terms of what have you learned, what are we prioritising. But it's also important that the whole multidisciplinary team then comes back together to hand over the plan, to add other things into that decision making, and to agree the actions that take place following the ward round. And then after the ward round, when's that patient's next review? How are we liaising with external teams? Who's implementing the plan? and who is feeding back to the patient on the progress of that plan. So there are a few things that help that. So having patient status at a glance whiteboards certainly help that. Having an afternoon huddle so you can check on progress of plans certainly helps that. And being clear around your processes at weekends is also important. So one of the recommendations in our report is that the Friday ward round should particularly focus on the weekend, is likely to take longer, is likely to have initial decisions and actions that cover the weekend. But there should be ward rounds 7 days a week. Their structure will be slightly different at the weekend because of the level of staffing. Clearly, that's not the case in all units. We'll find in assessment units, for examples, or intensive care units, that they are similar 7 days a week. So the environment is also important for well-functioning ward rounds. The physical environment is important. And interestingly, we've had some follow-up sessions with designers around how you can modify your physical environment to make that non-hierarchical multi-professional working more effective. And there are some key elements to that. Where's the space that the multi-professional team comes together to brief, to debrief, to agree the patient plans, to see the status at a glance of the patients, to follow up on plans? Is that room, is that space, adequately structured in order for that to happen? And when you're at the bedside, I'll emphasize it again, someone having a stool or a chair where someone can sit and communicate with the patient. Really, really simple thing that will make a big difference to patients. And what about confidentiality? How do we preserve confidentiality? That we're not talking about all patients in front of other patients, but actually that much of the discussion may need to happen away from the bedside and away from other patients, and then come and focus on the individual patient at that time. And there will be times when it's appropriate for that discussion to take place away from the bedside with the patient and family. Do you have a space where that can happen in a sensitive way, particularly for more sensitive communication? How have you structured that space? And then is the space for the team then to work in an uninterrupted way, either for confidential phone calls or for record keeping? All of these things of physical environment are important and are a deliverable within current environments if you spend a little bit of time thinking about it. Technology is a core part of the way we function on inpatient wards now. Common gripes are around mobile computers not being not maintaining their power, being slow to reboot, all of these things. And there is computer etiquette and practice that there should be at the ward level. So whose job is it to make sure the computer's plugged in so it's charged overnight? Who's going to shut it down and restart it so that it functions in a rapid way? Have you got the right amount of equipment at the right time so that people aren't struggling to use the same equipment? There are examples of ward rounds where there are 3 computers on the ward round, and people are more focused on looking at the computer than they are looking at multi-professional colleagues or the patient. So just be aware of those and think how you structure the use of hardware. Clearly, the information that we can have available to us now from multiple electronic information sources absolutely helps our decision making as well, and we should maximise the opportunities of that. More recently, during the pandemic, and this isn't included in our core report, but is included in a supplementary report about COVID-19, we're much more used to using virtual communication with patients and families, but also amongst members of the multi-professional team. So in my own organisation, the post-ward round MDT, that involves other people that work perhaps across a number of units or are external to the organisation, happens on a Teams call for every ward, every day at an agreed time, so that the wider team can come together, whether they've got a physical environment they can do that in or not. And similarly, on the ward rounds, we can connect with members of patients' families or other people that are important to them through mobile devices and not have to necessarily set up separate meetings for that to happen. Education, I've highlighted, is a key part of ward rounds. So this should be multi-professional working, learning. We've all got things to learn from each other and to contribute. I learn a lot from the pharmacist on my ward round. I learn a lot from the nurses, and I hope I support their education as well. Good practice is to highlight at the briefing that this is an educational process, to highlight to patients that education is part of the ward round, and to seek their consent to other members of the team, particularly those in training, to be involved. Sometimes it's appropriate for those people who are in training to take lead roles in the ward round as a training exercise. And again, we've got examples of good practice in that. But how we develop the skills of ward round practice and multidisciplinary working practice needs to be part of core curriculum and core development. And there are areas of the country where simulation of ward round practice and multidisciplinary ward working is happening as a routine for all members of staff in their ongoing professional practice, and we feel this should be much more widespread. So at the end of the ward round, summarising learning points is important, and again can be an opportunity to seek further learning by the time the team comes back together again. So as I've already said, none of the elements of good practice that are included in the report are figments of imagination. They are all happening somewhere in the UK or internationally today. So one unit who I will highlight work internationally doing what they call structured interdisciplinary bedside reviews. They've produced scripted dialogue between multi-professional teams that actually brings down the interactions to around between 8 and 10 minutes for most patients. They've also got examples of structured bedside handover that feed into the ward round process. Nottingham University Hospitals have done a lot of work with professionals in training and give examples of doctors in training in particular leading ward rounds and being supported in their learning. In my own organisation, we have ward-based pharmacists, so every acute ward has a permanent pharmacist on the ward as part of the multi-professional team working in an extended way, and they take on a lot of traditional tasks of other members of the team. There are other examples here, so wardrounds.net is a Swedish group where actually most of the ward round interaction with patients happens not at the bedside, but the patient is brought into another room. And in a general medical ward, they find that 80% of patients actually can get into another environment for that discussion. Surrey and Sussex is where they've done a lot of the simulation and training, and that's now spreading across Kent, Surrey and Sussex. And in Warrington, their ward accreditation scheme includes multi-professional ward round practice as part of their ward accreditation scheme. So there's work going on, and there are examples of good practice in our report and in the supplement of good practice. So nowhere is all of this happening together. So where do you start on your improvement journey, or the next steps of your improvement journey? Because you may well be working on a number of these elements. So we've included in the report a self-assessment template that breaks it down into different areas for you to look at your ward team level and say, you know, what's our practice like at the moment? Is it clear what the members of the team's roles are? Do we have structured shift handover? How are our briefs and debriefs happening? What's our structured documentation, etc., etc. So you can self-assess against that and then agree what your priority is for your next step in improvement. Because this is continued work. This isn't a short, sharp shock to get everything right. There needs to be continued improvement work on ward rounds, and it's a real opportunity for professionals in training to do improvement work and lead improvement work for a core part of practice that they're deeply involved in. So we've been fortunate that working with ESIS, and ESIS now taking the lead in delivering a breakthrough collaborative to improve and support teams to improve their ward round practice. So there are, I think I'm right in saying, 32 wards across England engaged in this first collaborative, which is now well underway, and they come together to share, to learn both their improvement practice and different elements of ward round practice, so that they're learning and improving together. They're coached throughout this programme by improvement coaches. And the most important thing around this collaborative is that we're learning from each other in terms of that improvement journey around what can work, what can't work, how we get the barriers out of the way. So I hope that's been a helpful overview, both to the report, to some of the work that's going on, some of the tips. There is a lot of detail in the report. There is a summary report which highlights many of the things that I've said. There is best practice examples. There's a separate report that you can refer to. It's all available on the RCP and RCN and ESIS websites. So I'll stop there, and hopefully that gives us plenty of time for discussion. Your contributions and thoughts will be really valued. Thank you.
Thanks, John. That's been really interesting. And as usual, for those of you who joined these calls before, we always like to get a bit of your feedback as well. And we've used Mentimeter a few times for that. So many of you will already be familiar with how we use Mentimeter. But if you haven't previously, we've just got a few questions we're going to pose to you using online platforms. So if you've got your phone handy with you and you just turn the camera on and just hold it up to the QR code, that should launch Mentimeter on your phones. If you're using a laptop or computer, you can go to mentimeter.com and enter the code 196014. And just for a bit of fun, you can put how you're feeling. There's a heart or a thumbs up or a thumb down or a bit of Batman. You may be feeling a bit Batman today, so you can pop that on there. So I'll give you a few seconds just to log in. So we've got 60 odd people on the call, so we expect to see quite a few responses to these questions, and these are questions that have been set by John, and just to give him some feedback as well. And maybe these can lead into a few questions afterwards. We've got a bit of time left at the end of the session for some questions. So the first question that John set, and we're going to put towards you, is what is your biggest challenges for multidisciplinary working on your wards? So just in general, so John talked before about, do we call them ward rounds? Do we call it multidisciplinary working on wards? So how you interpret that? What are the biggest challenges for you at the moment in your organisation? As you enter these should pop up as a word cloud on the screen in front of you. I think you get about 3 or 4 options to put in. So hopefully they'll pop up in a minute. It's always this tense moment. Oh, there we go. Tense moment when we hope it's going to work. So there you go, John. You can start seeing some engaging consultants. Yes, you've already touched on synchronised availability. It's so important, isn't it, about how we align our work plans with each other, staffing, time, nurses. I mean, we've been part of the ward round collaborative as well that John mentioned. We're experiencing this a lot about how we coordinate all our work. That's brilliant. And knowing the patients, quiet space, standardisation, and I saw a comment in the chat room about I think John's asked for a SOP, and then someone said that they use standard work. So it's just about that consistency of application. This is brilliant. Oh, it's really great feedback here. Thank you very much for contributing to this. So I'm going to move us on to the next question. I think we've got some real clear winners there around engagement, staffing and time. So the next question would be, what's your biggest, put my teeth in, what's the biggest success in multidisciplinary working on your ward? So we've talked about what's the difficulties, but where you seeing opportunities and where you're seeing successes at the moment in your organisation? And again, broadly across the whole of the ward, not just necessarily just on ward rounds. Yeah, ward round check. I love a ward round checklist. I think that's such an important. And anybody who's seen any of the work that Gordon Caldwell's done around ward round checklists, are really, really positive work around that. timings of ward rounding, timings again comes up again. You know, do we all know what schedule we all work into? Consult to the weekend, the positive step forward on that one. Therapist tenure, MDT approach, pharmacists. Again, it's an interesting point that you made, John, about you have your own ward-based pharmacist, and so every ward will have their own pharmacist, and I think many organisations may not have that. Then they may be sharing their pharmacist, so it's often that's a struggle. Starting on time, again, this is somewhere that we've picked this up on the ward round collaborative. Is that's a measure of success. That's sort of an organisation is talking about. You know, do we start on time? That's a really important thing to think about. It's a respectful thing. If half of the people there are ready to go and then other people turn up late, that's not very respectful for those who are there on time. Another important point there for me is data recording. How do we know how we're doing? You know, I've asked the question before about what's our purpose, what are we hoping to achieve on ward rounds, what's the purpose of that work. Electronic records is always helpful, but as John mentioned about keeping the patient at the centre and the focus rather than looking at computer screens, but having the availability of electronic records available to you. So excellent. I'm going to move this one on we will share all this feedback with you. I can do an export from this, so we'll circulate this round afterwards. And the last question would be, and my dog wants to join in the background, you can hear her yapping away. Top tips. So you may be doing some really great work. So as we shared these across the whole of the Line 16 teams, those people who aren't necessarily available with us today, what are your top tips for others on patient-centred ward rounds? What's working for you at the moment? I think that knowing the patient thing, you know, I know it obviously seems like an obvious thing, but if you have to study your patient or get some background on your patient even before you start the conversation, that's sort of 5 or so minutes before each patient that you have to get that background, and that's almost like that research that you have to do. So this is where I think, and this is just my observation or my view, is where you've got the ward nurse available with you on the ward round. The ward nurse being the constant there that has so much more information available and is such a rich source of knowledge. Consistency with the consultant chair goes back to the consultant of the week. Okay, you use the ward clerk more. Okay, there's I know we talked before about a scribe. Recognition of everybody, standard work, consistency. Like this comment here about the focus on unnecessary patient waiting and keeping that at the centre of everything you do. If that's what you focus on, then you're looking for those opportunities all the time, aren't you? So I'll give that a couple more seconds just to run through any more comments anybody wants to make. Really helpful. And so any comments or any questions that this may have stimulated? We've got 20 minutes now for the questions, so we'll let this one carry on running in the background. I'll leave this on now for a while, but in the meantime, Andy, I'm going to hand back to you. I think we're going to run the plenary session now.
Thank you, Nick, and thank you, John, for that great presentation. Really good, and it's stimulated some comments and some questions in the chat room. If it's all right with you, John, I'll go to the chat room first, if that's okay, and just cover off some of those questions. So John Scott fairly early on came in with a question around they have a policy for medically fit for discharge patients and medically optimised patients are not reviewed daily, but covered by the deteriorating patient policy. So I guess your thoughts on that, John Dean and John Scott, whether you want to expand on that point at all.
Yeah, thanks, Andy. So I really love the document that came out from the RCP and the RCN, but like everything I love, I want to change bits of it. That's all right. So so there is a bit in the document where it says every patient needs to be reviewed every day. Now we have a policy that says if you medically optimize, you've already been signed off by the doctor, so you shouldn't be reviewed every day. But the doctors are now responding to this ward round document saying, no, all the patients need to be reviewed every day, and we're in a bit of a conflict over it. And my view is, if the system worked as it should, the medically fit patients would be at home and we wouldn't send a doctor around to review them. So we should be treating them in that way. But I just wondered if there's a way we can bring that together.
Yeah. Firstly, that's really helpful feedback to know that's the way it's being interpreted, because it probably wasn't what was meant in the document. So remember, this is about multi-professional working, so it doesn't have to be the doctor that's reviewing that patient. The nurse looking after that patient will have reviewed that patient and can highlight whether there's a need for other members of the professional team to be involved. And secondly, if you have that board round in the morning, then it's clear that that patient may not need medical input and a review that day, and the whole team agrees to that because nothing's changed. So my personal practice is that at the board round, if someone previously we've made the decision around discharge and nothing has changed, we just check in and we say, so they don't need medical review today, and we all agree yes, and then we proceed. But if the nurse or someone else says, wait a minute, they fell out of bed yesterday, they're not as well today, then we make sure the relevant members of the multi-professional team have been seen. So I think the answer to your question is this is about the team, not just the doctor, and the focus of the board round in terms of planning who you need to see and prioritise. So it's the whole process of board round, ward round, post ward round MDT that is important, not just the middle bit. I hope that helps.
Brilliant.
It does. Thanks very much.
So John Scott, I'm just going to stick with you for a second, because another point that you've raised there is around, and I guess it's a question to John and the wider room really. Has anyone moved medical on calls to Fridays? I guess that's the handover aspect.
Yeah.
Over to you, John.
I've noticed that actually on a Monday we have a really slow discharge day, and that's predominantly because Monday is the post-take from the weekend, and we also struggle with weekend discharges. So the handover bit between Friday and the weekend is important, and Sunday is our worst discharge day, and that I think is because people are knackered from being on call from the previous Monday. And I've been talking to people about, well, which of the commandments says that the week on call has to start on a Monday? Could it not start on a Friday, and then you get continuation through the weekend, and the handover takes place on a Friday, where we get loads of discharges anyway, and the pressures are slightly lighter? And I was wondering whether anybody had done that, and if they had done it, could I nick their how did you do that bit?
Yeah. So general comment from me, and then there may be stuff that people can add from the wider room. So it obviously depends on the structure of your organisation and your system. So many organisations will have a system where they've got assessment units which run pretty much exactly the same 7 days a week. Others won't. Assessment unit guidance is that there is continuity over a number of days, but that doesn't mean it's Monday to Friday. It could be, someone starting on a Tuesday and finishing on a Saturday, or it could be whatever. So certainly in a lot of organisations in the assessment units, it's not Monday to Friday. People are working a serial number of days, but that's from a medical point of view. Doctors at all levels of career, and I think we see the same in the other professions. In terms of your comment about weekend discharges, again, my own personal experience, something we've put a lot of emphasis on in East Lancs. The key is the Friday planning. The key is that any discharge is multi-professional, not just doctors. So you need multi-professional decision making and action throughout the weekend period. I think Mondays are a problem because people are often reviewing patients for the first time, having not seen them for a couple of days. And the other bit is if you've got a system which is assessment unit into base wards, then that Friday handover of the patient who moves from the assessment unit on a Friday evening, and there are a lot of them, into the weekend, so that that early decision making on a Saturday and a Sunday happens, because those are likely to be your patients who go home on Saturday and Sunday. So building that into your weekend processes for their early review, and the handover on a Friday from the assessment units as well as the base wards is key. We recommend that the ward rounds take longer on a Friday, so that people have time to make those good weekend plans, and again, that should be planned. You may, from a multi-professional point of view, for example, need more therapy time on a Friday to make sure assessments are completed. If you've got less therapy staff at weekends for contractual reasons or work-life balance reasons, then you might need to structure your team in that way. Don't know if there's any other comments, Andy, in the chat around that, or other people that want to come in on that.
I think there's a couple flashed up in the chat. Jyoti's commented around having 2 handover periods, I noted. It might be worth just opening up to the wider room, just on John Scott's specific question there around handover days. Anybody else want to contribute at this point? But we'll come to wider questions shortly. But just on John Scott's point, any other comments around that at the moment? We take a hands up approach, that'd be probably most useful. Jyoti, can I bring you in?
Hi, I just wanted to say we did try. No one can work the whole week, especially in medical specialties. It's quite onerous. So always a split week works better. And we have definitely tried Thursday, Friday, Saturday, Monday, one person, and then so the weekend for that person is usually Tuesday and Wednesday. So they go off, and then somebody else comes in Tuesday and Wednesday, and that certainly worked quite well. And not only medical specialties, surgical specialties have had more success with this sort of a rota. I know our general surgery works like that. They have a different changeover time, and it's a Thursday. So yeah, it's something definitely they think of. But Scott, Philip has put something on packages of care not being available over the weekend, which is an absolutely correct point, actually. But at least it doesn't feel very onerous. Monday to Friday is very onerous.
And I think, thank you, Jyoti. And I think Liz Deutsch has also commented, and a point I would definitely agree with, is the continuity from the nursing perspective over the weekends. That's proved, certainly, my view on that is within nursing, that's proved far more difficult as we've moved predominantly to long days within nursing. To have that continuity over the weekends is critical, really, I think. Absolutely. So good point from Liz. And I think just sticking with Liz, the last question in the chat box, John, and then we'll open it up to the wider room, was I think Liz commented on your point around it's useful to have the nurse in the bay looking after the patients on the ward rounds rather than the coordinator. And I think Liz's point is very much around how do we change that culture? How do we start to make an inroad into that culture? Because it can prove quite difficult.
Yeah, it's a really interesting one, that, isn't it? And so from the survey, and we had quite a lot of discussion in as you can imagine, the working party around that. But I think our view is fairly clear. When you look at the issue of interruptions, who knows the patient best, who's the patient's advocate, all of that, it was quite clear that we need to make that happen. And it was interesting from the survey that the nurses, the doctors were saying, well, this never happens. Or they didn't say it never happens. They said it happens less than 20% of the time. And the nurses were saying it happened a lot more frequently, and that they absolutely wanted that to happen. So I think a lot of it is about culture and leadership, and a lot of it is both, and again, it's multi-professional. So I think there's something around the patient's own nurse being permitted to do that and expected to do that by their leaders and mentors. And I think there's something around the other members of the multi-professional team inviting that to happen and expecting that to happen. So again, my own personal practice is if I am at the bedside or I'm talking to the nurse in the bay before, I absolutely invite them to say, so what do I need to know about this patient? Is there anything that's important to our decision making here, and we make sure we hand over the information afterwards. So I think probably it's 50% cultural and 50% organisational.
Yeah, I agree, John. And I think it goes back to your earlier point fairly early on in the presentation, actually, is that ward rounds don't happen by accident. They take planning. And I think it's within that planning phase, isn't it, where, you know, we lay out what the expectations are of our ward rounds. Absolutely. I think now I've been very mildly multitasking, John. I may have missed some questions in the chat room. If I have, then we've got a little bit of time left. If I could open it up to wider questions. If I've missed your question, I apologise, but do feel free to put your hand up now and revoice it now. But if we can take questions with virtual hands up for any further questions, and then we'll take it from there. Philip Thomas, can I open it up to you?
Yeah, hi, how you doing? So I'm a geriatrician up in Wolverhampton at the minute, and I absolutely love the principles of what we're trying to achieve with this. The reality is, as the consultant on the ward, and I appreciate there's got to be bigger culture change here, I'm often the consistency. So this week, for example, I've had different junior doctors each day of the week. The nursing team changes, and actually, yes, there was a discussion about does everyone need seeing every day, but actually as a geriatrician, the changes in my patients are often quite subtle.
Yeah.
You know, they're just not quite right. And actually, it's only that consistency as it came up with the word cloud, which is important. Now, with everything that we're trying to implement now, particularly with a shorter ward round, realistically, how many people do we think we're going to be able to deliver, you know, all the individual facets of care of what we're looking for from a modern MDT ward round? How many people are we going to be able to see in a session? Because I worry we're going to see probably 4, particularly when you compound it with your IT, when you've logged on to half a dozen systems, once you've actually found a computer.
Yeah, I think you're absolutely right. You know, these are key challenges. I do think some of them come back down to planning. So, you know, how do you plan? How do you plan? You know, apart from, you know, sick leave and things like that, a degree of continuity of the whole staff on wards, because it can happen, and it does happen in some organisations. So that has to be part of your planning. I think a lot of it is specialty specific as well. So your point around your patients and the subtlety that you might pick up at the bedside in terms of them just not being the same today as they were yesterday. Absolutely take that. But your type of review is likely to be slightly different for those patients. I don't think we can put a number on it. I think, you know, there's a pragmatism in this, isn't there, between our workforce realities, our care demands, and the difference between different specialties as well. So your specialty will be very, very different than other medical specialties and surgical specialties, and a rehabilitation unit than an ITU. So, but from a purely medical point of view, the Royal College of Physicians has made guidance in terms of medical staffing for numbers of beds in our safe medical staffing, and clearly there are nursing guidance around that as well. And there's lots of different ways to structure it. So I think in terms of continuity, a lot of that's about planning, but sometimes you are. And I think in the modern world, we may have a different team each day, and we're briefing and debriefing in terms of that teaming and bringing the team together. And I think, you know, there will always be time pressures, and that's about prioritisation. That's why I think the board round is particularly important in terms of prioritisation. And the other thing that I find with continuity, dependent on your team structure, and it will be different in different organisations, is how you organise that team. So the continuity may not be at a ward level, but it might be at a bay level, or it might be, you know, a small number of patients at a time. I just think we have to think, how can we make the best of these? So I know I've not answered your question because it's a challenging world that we're working on, but there's just a few thoughts in that area. I think what's important to us is we say, OK, you know, none of this is perfect. There are bits that we can work on. What's the next bit? But I do think that the planning and the scheduling is fundamental, and the team's understanding their roles is fundamental. Because until we've done that, we're fighting uphill, really, aren't we? And you know, simple things, plugging the computer in so that it doesn't, and shutting it down at the end of the day and opening it up so it doesn't take 10 minutes to open each program, but it takes 2 minutes. You know, it's basic stuff that if we plan in at a unit level makes a massive difference.
Brill, thank you.
Thank you.
Great, thanks for the good question as well. Just to share, Liz has made a useful tip really in the chat room around nurses at the bedside being on the ward rounds. Their coordinators take over from the nurse to allow them to do that. So if we're thinking about how we change cultures, bit of a useful tip there. Really.
Yeah, and the nursing colleagues have had some useful tips around that. So, you know, and again, you know, it doesn't, you know, how do you divide? It depends on how many patients they're looking after. What's the role of other members of the team in terms of healthcare assistants? How do you, you know, change the dynamic of those roles and tasks at that time? How do you make sure it's not happening at the same time as the drug round? You know, there's really practical things that you can do. And as you say, you know, another member of the team taking over some of the core nursing work that only that professional can do. And only at that time, you know, there are ways that this can be facilitated.
Agreed. And it takes us back to the planning point all over again, doesn't it? Absolutely, it does. John, there's no more questions. There's no more hands up in the chat room. Last chance for anybody. We've got a few minutes left. But if there aren't any more questions, I'm going to take us back to Mark to close.
Yeah, thanks, Andy, and thank you, John, for that really, really helpful, enjoyable session. That is our 7th session. Our 8th is upon us. Tomorrow we have our very own Liz Deutsch is going to be sharing some thoughts on writing for publication. So we look forward to that very much. So just to say, on behalf of myself, Andy, and the rest of the team, thank you very much for spending time with us today. And we look forward to seeing you tomorrow. Thank you.